Hello, it's lovely to be here. Mostly I'm taking off my researcher hat today and putting on my practitioner hat because I really want to tell you a little bit about the Alexander Technique and what it might be able to do for you. So why have I chosen this title of Embodying Mindfulness? Well, some of you might be familiar with a cartoon like this, which shows how it's very easy to have our mind full rather than being mindful. Just life gets in the way. We get caught up and obviously has all sorts of negative impacts. And practices such as mindfulness can help us come to the present a bit more. And I was wondering, well, how would you portray this if you were trying to portray the Alexander Technique rather than mindfulness? So this is what I came up with. So through the Alexander Technique, we do learn to become more present, but as a whole mind, body, self. So here we're very much part of the picture. We're not just in our heads looking out or in our heads looking in. So you could describe the Alexander Technique as embodying mindfulness. It's not a meditation practice. Indeed, it's not really any kind of activity per se, although we do have a recommended daily Alexander lying down practice that helps with the learning process. But rather, the Alexander Technique is a way of thinking and of being that then is with you all the time as you go about your daily life. Now, F.M. Alexander was around a long time before the current explosion in popularity of mindfulness in our culture. And for him, the mind-body is indivisible. So whatever you're thinking now, whatever I'm thinking now, will be playing out physically in some way, and vice versa. And the wider world is slowly catching up a little bit, at least now acknowledges that there is a link between the mind and the body, but of course linkage still implies two separate connected entities. So Alexander was actually a bit ahead of his time. So what is it? Well, it's a taught self-help method for self-care and for change. And what it enables us to do is to have more conscious choice over how we respond to life, rather than just being stuck in habit, and whether these are physical habits or thinking habits. And certainly, the Alexander Technique and mindfulness are complementary. Well, I would argue, and obviously I would, that the Alexander Technique has got much greater potential if you really want to transform your life, because it really is dealing with the fundamentals of us as humans. But it's not a quick fix. It's something you have to learn, and it's something you have to apply. And unfortunately, that does usually take one-to-one lessons. So before I say a little bit more about the Alexander Technique, I thought it might be helpful maybe just to have a little peek into the experience of one of my clients. So I'm going to tell you a little bit about Daisy, who's agreed for me to share some quotes that I've taken from my case notes from her lessons. And hopefully the selection of her comments will show you or give you a bit of a flavour of the learning process. So Daisy came, she's been coming for a few months now. She came really as a way of finding a better way of looking after herself. And she's very tall as well, so she's particularly concerned about her posture. She's a young woman with HSD who has not yet had a proper diagnosis, but she's had years of constant pain, as well as fatigue, weakness, and stress, all the things you're familiar with, and obviously you were very fearful of overextending. Right from the start of lessons, she found that she was actually able to begin to apply what she was learning to herself as she went about her daily life. So I'm going to give you some little snapshots now from her lessons. So in her second lesson, she said, oh, yep, she'd got into a bit of a mess, she was in lots of pain, but the Alexander lying down helped her get out of it. During her third lesson, we were exploring standing balance and proprioception. And Daisy realized that her habitual way of standing was actually putting quite a lot of stress on her joints, but also then it was really easy to start trying to balance, and that's not going to work either. But through the hands-on work, she had an experience of standing in balance pretty effortlessly. And I learnt an important lesson that day too, because inadvertently I said, oh, just think of freedom in your joints. Oh, that was not a helpful thing for her. That was not a helpful thought. So she put me right. And luckily, as Alexander teaches, we tend to have lots of different ways of saying the same thing, basically. And we found together that actually the thought of softness in the joints did help her to release some of that unnecessary excess muscle tension while maintaining joint stability. Lesson 5, now this is after years of constant pain, she reported that she'd had a pain-free week. But the thing is, you have to keep the thinking and the awareness going, or the old habits return, and particularly this is true at the beginning. This quote from another lesson nicely illustrates the self-care nature of the Alexander technique. And here, an experience of moving that was better coordinated, in balance, and therefore less effort. And Daisy finds she's thinking about it a lot more, but then she also realized that even when she wasn't thinking about it, quite often she was moving in balance. And then this quote really nicely illustrates the all-encompassing nature of the technique, that she was actually making much faster progress with her psychotherapy. And this shows how self-awareness increases. And again, how we're actually enabling, fundamentally that's what we're doing, we're enabling people to sort themselves out. And here we can see that unhelpful habits actually can and do change. And here's a quote showing the embodying nature, giving us a better sense of self. And this is the final one I'm going to show you. So, she still has relapses of pain, this is no magic cure. When she does, it's usually when life gets on top of her. But now she finds she usually knows how to get out of the mess. And really, it's really helped her self-confidence in particular. So how did these changes come about for Daisy? What is it that she's putting into practice? Well, before answering that question, I'd really like to just take a little step back. I'd like to consider that how we are now as adults, whatever state we are in, is a manifestation not just of our genetics, but also of our life's experience up to this point. More specifically, a reflection of how we've lived our lives moment by moment and the cumulative effect of this over the years. So, for example, in this slide, just notice the difference in the way the young child is sitting compared with the two adults. Now, in most young children, the natural mechanisms for support and balance work pretty well. So they can move with good coordination, minimum effort, and they can sit with poise. Now, of course, depending on our own individual genetics, we might be starting from a slightly different place from this. But my point here is that wherever we start from, as we're growing up, we all adapt ourselves to this complex and increasingly demanding world. A world that's very different from the one that we evolved to live in. And if you look at the guy there, that's one example. Because our mind-body is not separate, where our attention is, the rest of us wants to be. So I can start off on my computer typing away like this, but I get so engrossed in my work, I end up like that. We've all been there. So for all sorts of reasons, our general functioning tends to deteriorate as we fall into these habitual patterns, and these patterns that are interfering with our natural postural support, movement coordination and balance. And hand in hand with this, our mind bodies tend to become hyperactive as we try to juggle with life's demands. Now, if you layer on top of that what happens whenever we encounter any difficulty or challenge, well, we try harder, because that's what our whole culture encourages us to do. But basically, all we're doing then is we're doing the same thing, but with more effort, more muscular tension. So really what we need to do is change the way that we're actually doing things, and that's where the Alexander technique comes in, because essentially it's a method for change. So here's some examples of me working with clients, doing everyday activities. We also usually do some work with the person lying on the table. So So we're teaching using both hands-on and spoken guidance so that the individual learns the Alexander Technique both experientially and cognitively. They're having repeated experiences of moving, standing, sitting, etc. that are non-habitual, inherently easier. They're also becoming more self-aware and learning how to think differently to give themselves more choice over how they respond to what life throws at them. In this slide, you can see some common habitual patterns. These are common to all of us, regardless of whether or not or to what degree we may have hypermobility. And these pictures might give an idea of the way in which we can rediscover some of our postural support and balance, and how we can work with our anatomy rather than against it, using our joints and our muscles appropriately. And what's not happening here is learning how to stand up or sit up straight with all that extra rigidity and tension that that would entail. So the most common reasons for people coming for Alexander lessons is pain, often back or neck. They also come for stress, anxiety, indeed any health-related condition, from Parkinson's through to fibromyalgia. But we also work with musicians, actors, and business people to help improve their performance. And quite a few of these people will have hypermobility, some degree of that. Don't know exactly what proportion. In my experience, it's a lot more than the supposedly 3 to 4% of the general population. But whatever the reason that someone starts a lesson, they're going to be helped to quieten their overactive mind-body and improve their general standard of functioning, their breathing, their postural support, their balance and their movement. And in so doing, they will discover a different sense of themselves. So we know from clinical research that Alexander lessons can be very effective for some chronic pain conditions and also for helping people reduce disability, whether that's from back pain or neck pain or Parkinson's. But how do these benefits come about? So in this slide, it's going to summarize how the Alexander technique might be working, and it's on different levels. So in lessons, we're using hands-on and spoken guidance so that people learn both through experience and through changing the way they think. But in terms of what they're actually consciously putting into practice, it's these core thinking skills of quietening self-awareness and directed attention. Now, research has shown training in the Alexander technique leads to improved postural tone, movement coordination, and balance. And this is from a clinical trial that I've worked on, showing an increase in self-efficacy, greater confidence in your ability to manage your pain without having to resort to medications. And finally, in this trial, we also did in-depth one-to-one interviews with some of the participants, and here are some of their comments. It's not about what you do, really, it's what you're thinking. Much calmer, I can take a step back. And it really shows the enabling, empowering nature of what it is. So, to finish, people begin lessons for a whole variety of reasons, and some of those people are going to have hypermobility. A woman with EDS who came for lessons recently said she'd been told nothing more can be done. Well, from our perspective, that's a very common thing for people to be told. It's never going to be true, because whatever you're starting from, if you're interested in helping yourself, the Alexander technique can make your life a bit better. If you are looking for an Alexander teacher, do make sure they're STAT registered. Then they've had 3 years of training and they're adhering to professional codes of conduct. There's a national teacher directory on the website, and I suggest call up a couple of them and ask them what their experience is of working with people with EDS HSD. And the reason I'm saying that is that it's important that your teacher understands something about EDS HSD. And they should do, because over recent years we've had many great continuing professional development workshops and articles by colleagues such as Julie Barber and Laura Tuttle. So, if you have the opportunity, I'd suggest it's well worth finding out about the Alexander technique, whether it's an approach that would suit you, and if it does, it will enable you to make changes that you want to make, to change physical and thinking habits that are holding you back. And out of that process will emerge benefits in many different areas, some of which I've listed here. Okay, thank you.
Okay, can I welcome back our speakers, please? It's Phil and Linda here. And Alan, thank you. If anyone has messaged Dr. Hakim directly, he hasn't been able to see them because he's been busy at Hedge all day. So either resend them to on the subject or stand up by microphone, because I won't be able to see those messages. Okay, we'll start over here in the centre. Thank you.
Hi. I work as a psychodynamic psychotherapist, so I work with adverse childhood experiences. I also have HSD, and I have a concern in my work about GPs referring clients for anxiety and depression. And because I have what I have, I'm able to work out that some of the symptoms they get are physical and not mental. So the concern is, if I didn't know what I knew, there would be some therapists carrying on with the whole anxiety. Now, I'm not saying there's not anxiety there, I'm talking about specific symptoms. And when I've said to my clients, go back and see your doctor, because that's not an anxiety symptom. I've been doing this 15 years now, so I work out what's what. They go back to the doctor, I say, you need to go back and get a referral to find out what this is. And they find out what it is, and they come back and say, yeah, it's some problem with my stomach, and it refers to EDS or HSD. So I just wonder if you've had those experiences, and how do you get the message through to GPs or any other medic that they're causing problems there by just assuming that their clients have anxiety when they don't?
There we go. That happens all the time, actually. That's really common. And because, in a sense, GPs are not so good with chronic pain, medically unexplained symptoms. With chronic pain, the best that they can do is, often give painkillers. So it's very difficult. So they're always looking for somebody to shed some more light on it. And I think it's our job to think about, okay, we've done an assessment, we think some of this is physical, and maybe it's our job actually to contact the GP, send a letter back, and by doing that, we're educating the GPs. Sometimes I go, where I work in my NHS practice in Kingston, I go to the GP kind of like seminars, and I talk about kind of like EDS, because I'm just trying to increase their knowledge of it. But in terms of their training, they won't have had anything on EDS. So I think it's one of those things where we're slowly educating people through lots of different means, but I suppose we do have to take on the task of actually educating the GPs.
It does work. So absolutely concur. It happens all the time, every day, every clinic. That's that story. And it should work both ways. So if I see somebody who comes in and much of what we discuss is a realization that there are lots of psychological issues and maybe less on the physical, then I should be able to just have a completely normal, mature conversation with somebody from psychology or psychiatry, wherever the support's needed, to say we need some help and we need to work together to, to support this person. So it works both ways. But the thing that I find the most distressing, to be honest, is when somebody is sent to a psychologist or a psychiatrist, and the psychologist or the psychiatrist says, fundamentally, this is not a psychological or psychiatric problem, it's a physical problem. And when the individual goes back to see the doctors, they completely disbelieve the report of the psychologist or the psychiatrist and continue to pursue this avenue of it being a psychiatric issue. And I just do not understand that at all. And that tells me that in those sorts of situations, this experience and understanding of the physical issues is just completely lacking. They just don't have the skills. Now, I am the first person to say it's fine not to have the skills. It is not fine to ignore the fact that you don't have the skills and continue to pursue that pathway. It's completely inappropriate and it's bad for patients.
We've got a long way to go. I've had two experiences of talking in London to the Medically Unexplained Symptom National Group and also local psychiatrists. And it's very interesting just seeing how the pennies start to drop when you present the story that we have. And it does mean that we've got to do a lot of education. We do, with the HMSA website, we have a meeting in a box that you could tell your GP about, because what we think, I think we all agree that it has to start with GP education. That's where it's got to be, because a lot of the less severely affected individuals just want a diagnosis and don't necessarily need a lot of intervention. They just want to know, why have I got all these symptoms? So I think the whole issue of somatisation as a philosophy for psychiatrists is a big worry.
Okay, question for yeah. Question for Alan. In using beta blockers, how about using something more specific such as antenolol that is beta 1 specific, easier on the lungs, and does not cross the blood-brain barrier, so it's a non-sedative? The idea would be to break the feedback mechanism of perceived increases in heart rate, increasing symptoms of anxiety further.
So who's been reading up on their beta 1 and beta 2 biology? Well, no, I mean, absolutely. I mean, atenolol is in there on the list. Agents like metoprolol and bisoprolol are often used because they're actually better tolerated for the various types of side effects that they can be. But there's no reason why you can't use atenolol as a perfectly reasonable beta blocker. They've all got beta 1 activity, and the first two have got some beta 2 activity. So I don't know who asked the question, but it's perfectly reasonable to use atenolol. Thinking about agents that are used for beta blockade to control blood pressure in things like vascular, EDS, metoprolol and bisoprolol and celiprolol are the sort of more typical ones to go for, because they've got much more multi-receptor activity.
Thank you. And this is not a question but a comment that some people may find helpful. In addition to the BACP, the professional body for counsellors in Scotland is COSCA, Counselling and Psychotherapy in Scotland, and they have a list of accredited counsellors on their website. Okay, bear with me please while I just go through the questions. Oh, hello, there we go, go on.
Are we there now? Can I just say that it's not very easy to stand up here and make this comment, but I'm going to do it anyway because there is a purpose for me, the same as everybody else, to be standing here. I want to put to the panel just exactly what's your opinion on trauma induced by professionals to families out there that are struggling to get any help and support. I was in a position myself after 9 years of looking for assessment for my son, who did turn out in the end to be autistic, and it turned out that my other 2 children were also autistic, and I've been diagnosed myself. In the process, 4 years ago, I went through a traumatic child protection situation where it was assumed that it was my mental health that was the problem. And I've spent a long time trying to understand and comprehend how people can be put in the position that we are as parents when we are trying to get the best for our children, and now in a position that are frightened to do so because of things that have been done to us in the past, when, you know, we've been in a position that we don't know how to handle it. You know, I can be quite an articulate person, but I'm better writing things down than I am addressing things face to face. So I really want to put the question to you that there is families out there that find that they're completely in a position of being soul destroyed by prolonged outside agencies who appear to conspire but don't take ownership when proved wrong. Now, I was in that position and did nothing about it because I have no strength left anymore. All I wanted was an apology. I never got that. But I'm now in a position that all my autistic children show signs of hypermobility. And I'm in a position now that I am terrified to take it further because am I going to be subject to more stress? You know, there's kids out there that are suicidal, that have taken their lives because of professionals, and there needs to be a time that this stops. People need to start listening to parents, you know, because at the end of the day, we know our children better than anybody. That's my little sorry.
So absolutely, and you know, on the positive side, there are also doctors like this, and I think it doesn't excuse that, because there are terrible, harrowing, unforgivable things happening to families out there in the UK and all over the world. And this is an opportunity to mention that we are actually bringing together a round table of experts that will be meeting at the Royal Society of Medicine in London in April, that are focusing on the paediatric issue that we are seeing all over the world. We're bringing together policymakers, members of the International Consortium, and members of the Paediatric International Consortium to try and tackle this head on, because it's not good enough. We need to make a difference. We're taking that challenge on, and we want to work together with everyone to try and make that better.
Terrible trouble with buttons here. I'd like to, we're recording this, right?
Yes.
I would like your permission, if we may, to actually use the way you've asked your question today and to take it to this meeting as one of the examples of a real story with real compassion behind it. And I'd just like to, we'll check afterwards with you if you're all right with that, but I'd like to really thank you for asking that question. It's so pertinent.
I suppose in the meantime, I think, yeah, the way you asked that question was absolutely great. So I'd almost start there and think about going to your GP. And I've advised lots of people to do it. If you don't feel that your GP is helpful, unfortunately, I've had to ask a lot of people to try and change GPs. But really, if you can find one health advocate who is on your side, who can understand, and try and get that person to do as much as they can within the system, that would be really useful. I know that's not easy, but that's just one thing that you can do in the meantime before all this other stuff comes out.
So I have with that kind of depressing notion of that's going out there, something that is inspiring, of someone that's tuning in saying, I work as a physiotherapist and I want to help these patients live a healthy, active, independent life. I often struggle to manage patients' expectations of what we can and cannot do. When I ask, many patients tell me they want me to take their pain away, or a doctor has told them they need to go to a gym. This must be terribly frustrating for patients. How can we as healthcare professionals better manage patients' expectations of treatment options for EDS and HSD? So there are people out there willing to help us, which is great. Can we have an attempt at an answer on that question?
Well, I think we are, aren't we?
So how can healthcare professionals better manage a patient's expectations of treatment options for HSD? Your advice to a fellow professional?
Better manage the expectations. Well, I suppose the first thing is to have a conversation with the person that you're working with, your patient, as to what their expectations are. I think we spend a lot of our time looking at the current functional issues, various symptom profiles, thinking about our own expectations of our own interventions, goals to be set. Are these goals realistic over a period of time? What are the more long-term goals? So I think if you don't start with those sorts of conversations, can be quite easy to go a long way down a pathway and have realised that you've never actually set a set of expectations. I wonder actually whether how many people in the room have gone into the room to a clinic, to a consultation with no expectation. Hands up if you've gone in with no expectation that anything was going to come out of it. Yeah, so it works both ways.
There are a lot of hands up.
There are lots of hands up. So work with your patients to identify the expectations and be honest about what you feel you can and can't provide. And equally for patients, everybody in the community, have in your own mind what you feel your expectations are. It's okay if they're under, because if we think we can do more, we'll try and boost you. It's okay if they're over, because if they're over, we need to have a conversation and bring them back down to something that's a bit more realistic. It doesn't matter either way, you've just got to have the conversation.
Absolutely. Is psychotherapy still useful if the patient has little childhood memory?
Yes. Yes, because there are ways of finding the memory. So using EMDR or EFT, there's ways of finding that memory. I haven't talked about it here, but also to some extent, hypnotherapy, you can find the memory. However, finding the memory is not necessarily so important. It's working with the present symptoms. So in the absence of the memory, what are the present symptoms? And are there any other memories that can be remembered that feed into the problem? And so with the CBT approach, you're always trying to work with the here and now. How can the person cope in order to relieve their suffering and distress in the present?
Thank you. Yes. Thank you.
Yeah, hi. Briefly, my work background is in mental health, and both as a nurse and as a social worker. 30-odd years ago, I had what was thought to be a very minor accident, and went to see an orthopaedic surgeon. I was told, can you bend over, touch your toes? Yeah, no problems. I mean, by this time, I was experiencing severe pain. I couldn't stand for more than about 5 seconds without blacking out. As I said, saw this orthopaedic surgeon, was told, asked, can I bend over, put my hands flat on the floor? Yeah, piece of cake, no problems whatsoever. The report that I got from the orthopaedic surgeon said any pain this woman thinks she might feel is probably a psychological reaction to her husband's death, coupled with a little bit of paramedical knowledge. As a result, I lost my workplace pension. I had to give up work. Sort of 35 years later, it's still impacting on my life because of the whole financial thing. And yeah, it's just this whole transition from being a respected mental health professional to just becoming this woman. And it was just an incredible experience. So yeah, just wanted to sort of share that sort of it's not always good.
No, it's often not, and I'm afraid that I still see people in clinic who come with those sorts of stories. And there's a couple of things that come to my mind in your story. One is this perception that somehow, because you can move apparently more than normally, that you can't have sustained an injury is nonsensical. Equally, we were talking about earlier on today how you can dislocate joints and it not be painful. People who've got very unstable joints can dislocate their joints and it's not painful.
I actually had an L4-5 rupture.
Right.
But it was painful rather than natural.
So there are all these misconceptions around how pain and the mobility and the impact on function somehow should both track with each other. High levels of pain, clear evidence of reduced function. But the other thing that I do, somebody who has that kind of story, is ask the question, who wrote those things about actually formal, correct assessment of the diagnosis that they made and the statement that they gave, so that there was formal evidence that they'd worked this through. And I have to tell you that the vast majority of the time, the answer's no, they did not. And I have cases where people have been given various psychological diagnoses and there has been no formal assessment by that individual. I love my orthopaedic colleagues, but I doubt very much that any one of them would ever have the time, and very few of them would ever have the knowledge to do a formal psychological or psychiatric assessment in that way. The problem is, at the professional level, when that's down on a letter by Mr. So-and-so, who's a very important person in the local hospital, we're in trouble. And right now I spend my time getting those statements off people's letters because it leads to the kind of trauma that you've just described.
Hi, it was two questions if there is time. The first one was to do with the gut and the psychological and emotional health, how what we eat, how our diet can impact on that. It was just to get the feedback from the panel and what they think on that.
Yeah, so this really brings us back, I think it's working out. This brings us back to the issue of the microbiome. And, you know, everybody's got a different microbiome and everyone has a slightly different reactivity to different foods. So it's a very complex area. I think it's true to say that we're just starting to understand it. So it's breaking news, really. And I think you'll see a number of the speakers that come to the Ehlers-Danlos Society, but even back in Ghent, we had a speaker go into great depth about this, and that's available, I think, for you to look at. It's incredibly complex, and we're only just starting to unpick things like celiac, carbohydrates, all of the mast cell activation, all of these things is, I mean, it's exciting times for those who are academic. It's not so good for people who are right in the middle of it, working their way through. And I think it's true that most of my patients work their way through to some kind of tolerable existence. But it's very, very difficult. And you never know quite when you're going to bump into something unexpectedly that's going to knock you out for days. So a very good question, but no simple answers.
At lunchtime I noticed there was about a third approximately that were for the special dietary requirements. So I don't know if a lot of people are figuring it out for themselves, that it's maybe having an impact. But the second one, if that's okay, was about time management. It was slightly touched on. If this is an actual problem within people, within the EDS community. I noticed again there was a lot of late comers, and I'm notoriously late. Everywhere I go, I'm late. I'll normally try and laugh it off, but it's embarrassing and it causes a lot of problems. But it's really whether or not this is like the actual physical challenges of the condition, as it's constantly changing. One day it takes 10 minutes to have a shower, the next day it takes an hour. It's managing the time that way, or is it an actual condition of time blindness? It's just to see what the feedback on that was.
Yeah, I would say the time management problems seem to be universal. My experience of this particular population is that time management does tend to be related to physical mobility and physical limitations, trying to get around. So while we can think about time management, particularly for people in relation to their work, from my experience, it doesn't necessarily, it can do, but it doesn't tend to come up much deeper than that. Because it can go back to your childhood, but it doesn't tend to go much deeper than that in this population. So from my experience, it does tend to be because of the physical limitations around the body.
That's great. It's a relief to hear that. Thank you.
Hi, sorry. I think one question I'd like to ask is, I think a lot of people here would have spent a lot of money in the end trying to source the right doctors for their conditions. And it's knowing when to stop, when to actually realise that actually we're not going to get any further with the NHS at the moment, and we need to take this in our own hands and take a bit of ownership until we can then move everyone forward and bring everyone together. And I was wondering, have you got any advice what the best way is to collaborate everyone that you're trying to work with together?
Bring everybody together. As somebody who's worked in the NHS for many, many years and now works privately, I have huge amounts of sympathy with regards to access to people, and we see this both within the doctor side of things, the therapist side of things, podiatry. There are certain types of techniques that aren't even available on the NHS, right?
Two pain clinics.
2 pain clinics. So it's a very real phenomenon. One of the pieces of work that we've been trying to do as several groups, HMSA, EDS UK, the work we're doing with the Ehlers-Danlos Society, is at multiple levels work with the NHS to try and improve the understanding, the commissioning of services. So at one level, we're right up there talking to very senior commissioners at NHS England. At another level, well, let's not call it levels. In one place, we're talking to commissioners about how we improve services. In another place, people like Philip are going around Kent and educating and training and bringing networks together. We have the ECHO programme that we're running, which is this all teach, all learn education programme that anybody can jump onto from anywhere, whether they're NHS or private, it doesn't matter. We have masterclasses running up and down the country. So these are all ways that we're trying to sort of facilitate the development of much greater skills within a multidisciplinary team. Does it take a very long time? Yes. Even in the private sector, Professor Graham's still here, it took an extremely long time for us to gather our network together. But we had to start somewhere. And we're working closely with colleagues all over the country where they may be the catalyst for something. Philip was the catalyst for something in Kent. Maybe just sort of share your experience of what's happened in Kent over the last couple of years as an example of what can happen.
Yes, I mean, I've probably spoken to about 1,000 health professionals in Kent, including 200 GPs, and we give them this clear sort of outline of the questions you need to ask, the things to look for, and the simple things that you can do in primary care, like, if you've got POTS, take more fluid, more salt, simple things that make big differences, and things like mindfulness, things like Alexander Technique, which we have got in our pain clinic. We've got Alexander teachers there, and kind of increasing the toolkit. And all three charities have been enormously helpful in allowing us to say, right, go and look at this, or there's this conference, come to Ghent, whatever it is, it's out there. One thing I did want to say about medical progress is that Alan and I have been through a period of time with a different condition known as rheumatoid, which we've got much greater understanding about. When we started, certainly when I started in 1980s, there wasn't really an effective treatment for an incurable condition. And at every clinic, you would have 3 people in wheelchairs who have just had totally destroyed joints. The picture has changed over my lifetime in the NHS to something which is now eminently treatable. And although we don't know enough about this condition, there is cause for optimism because so much international understanding and research is going on that I think there is cause for optimism for the future because things do change in medicine.
And I think to build an army, you need 1 or 2 leaders. And everywhere that we've been, where we have successfully started to develop programs and networks, there's usually been 1 or 2 people who have been catalysts. And they might come from doctors or therapists or other people. So if you know in your area of people that are sort of in the thick of this but don't have a lot of support around them, that's where we were 10, 15, that's where colleagues are now. It's okay to start somewhere with very little and build. And one of the opportunities that we now have with the way we can network using virtual groups and everything else is that is so much easier to do in terms of having conversations with each other. A colleague of mine took a masterclass on physiotherapy up to North East England last week, 2 weeks ago, when we were at a staff meeting, and she ran a full program there. Fantastic. Loads of people there that were grappling with all the sorts of things that we've been talking about today. And I dialed in from 5 hours behind on the east coast of the States and joined in, and we all had a really good conversation. These things are easily done. It just requires people locally to have an interest. And if they're a catalyst, get them to contact us.
I just want to say thank you because I think it's about pulling the whole families together. We've talked a lot today about patient having that psychological support, but I also think it's very important for our partners too as well, because they're not just dealing with one, they could be dealing with children as well, and this up and down of the ADHD type of symptoms as well on top. And I just want to say thank you for the whole day anyway.
Thank you.
Off the back of that, I just wanted to ask, as we're here in Edinburgh and this particular country has a pretty poor demographic of EDS clinicians, is there any advice you can give to patients in Scotland, specifically people who are desperate?
I would say one piece of advice that I would give to anyone in Scotland and anyone listening from all over the world is tell the professionals, your GP surgeries, about EDS Echo that we've set up, because that was set up to create 1,000 EDS experts by 2022 by this all teach, all learn model that's free to take part in. People can dial in from anywhere where they are in the world, present their de-identified case studies that could be people like you sitting in this room, to talk to experts to find out what the best care is for those people. And through that process, that's how you create more experts, because there's actually no such thing as an EDS expert. Doesn't exist. You have rheumatologists, geneticists, gastroenterologists, you know, and on and on and on. And they are individuals that have taken an interest in this condition and been willing to educate themselves. And that's all we need, all around the world, more and more, because we still have a small collection of these experts that have dedicated their careers often to this condition, and for that we're so grateful, but we need many more. And everyone can help us do that and build that army of experts, because it's not impossible. It just requires their willingness to learn.
Yeah, can I tell you a little story about somebody who was brave enough to come down from Scotland to see me in Kent? And that initial consultation, I was able to kind of outline certain things that she needed to do. And I know that Julia has seen her. So she's had some Alexander lessons in Edinburgh. I then reached out to my gastro colleagues, because that was a big thing. I said, who do you know in Edinburgh who could deal with this? And so, so there was just two examples of kind of remote control, and she's doing really well. I think as our network increases, and a similar story from a ballet dancer who came to me, who was going back to Madrid, or was it Barcelona? And I said, I know somebody in Barcelona, there's a professor out there, and we were able to plug that individual into the hypermobility network in Barcelona. So it's networking that I think makes the difference.
Yeah, absolutely. I can't do this afternoon.
That's it.
I've got some kind of motor dysfunction. Absolutely about the networking, and we're growing and growing that network, and part of the work that we're doing is extending the kind of international consortium with all of the expertise, and it's incredible once you do know. Sometimes I feel like a Yellow Pages, so people will come down to me in London and they'll say, you know, how are we going to do this? I actually already have many contacts. What I can't understand is why those contacts don't know each other locally. And I think one of the things that we need to try and do is get them networking closer together, however we can facilitate that. So network. We do know the people. I know there are people up here because I'm referring people back up here all the time. But the other piece is the whole conversation with NHS Scotland and commissioning. And some of you will know from last year that this conversation did start, and NHS Scotland was looking at some of its data, which is the information it has on patients that are being transferred down to England for assessment. And I know that conversation is still happening. I did promise a couple of people who asked me a very similar question earlier on that I will email the colleagues that I've been in touch with, because they've spent time with me starting those sorts of questions, and it was one of those catalysts. So this isn't a clinical catalyst, this is a service delivery commissioning catalyst, and it started. It will take a long time, I have no doubt, because these things do. But there is this kind of undercurrent of work that's going on.
And to remind you all that we do have our medical directory, and we do have people from Scotland on there. So it's worth checking that out and seeing if there's anyone local to where you are.
Can I just add as well, if you're in sort of this area or north of England, we're very happy, and if you're interested in finding out about the Alexander technique, we're really happy to organise some workshops for people to get together and find out what it's all about.
See, there's a lot of people willing. You know, when we published the 2017 criteria, there were 90 people in the consortium. There's now 140. That's just in 2 short years. So it's growing. It is changing. We've all got, as a community, PTSD of this whole process of 20 years of no updated nosology, no real research, no funding, you know, and there is hope on the horizon now. It's just going to take a really long time to repair that damage that was done over such a long period of time. got time for two very quick more questions. So up there and then to the middle.
Hello. So I have a question regarding children. I have EDS myself. I was diagnosed 3 years ago. Recently, my daughter has displayed some symptoms, which she was referred to our local rheumatologist at the Sick Kids in Glasgow. They said that she was a normal, healthy girl with nothing wrong with her, even though her collarbones dislocating, her shoulders, etc., other things. So I took her to see Professor Chikanza in July of this year, and she was given a diagnosis there. Going back to the GP, from seeing Professor Chikanza, he had asked for some specific tests to be done on my daughter, some extra bloods. And the GP, after seeing him and read the Professor's letter, he said there was a marked contrast between the local NHS rheumatologist and Professor Chikanza's letter, and that if I didn't mind, could he re-refer her for a second opinion. We were there yesterday, and again we were met with the same sort of attitude that she was quite normal. They agreed that she did need physiotherapy of some sort, but they said that there was a whole buzz, was the correct word, around EDS at the moment, which obviously is what you're trying to create, is a buzz and an awareness, which we all know. But she said that she was unwilling to acknowledge that she had EDS. She didn't think she had it. She wasn't going to label her with anything. She didn't believe in the Baton score assessment for children. I'm aware of the statement that came out from the British Society of Rheumatologists. I know that there was a letter sent back from yourself and EDS UK. So really my question is, does anybody know why there's such a reluctancy to diagnose a child, and why there seems to be this problem that they don't have anything wrong with them? Because today's all about the psychological and emotional health, and I feel that telling a child that they're perfectly normal, when my daughter's had to give up a dancing career, etc., she can't do certain things, what does that do to her mental health, to say that she's normal? And we don't have any services available. On one of the letters it was written that I had a shopping list, and that they were worried about me trying to get a medical diagnosis for her. So as again, we come back to the sort of child protection sort of issue. So it was really just to see whether anybody knew why the NHS rheumatologists are unwilling to address this.
Yeah. I think it is a real problem. I think it's probably the case that a lot of children who are hypermobile, that it goes away by the age of 14. That's what the paediatricians are saying. And that group who don't go on to get anything more complicated could be reasonably reassured. But the problem is, how do you know when it's an 8-year-old which way they're going to go? And Alan and I spend a lot of our time at the end seeing 25-year-olds who've had clues all along the way from that kind of paediatric contact, and then an orthopedic contact with subluxing kneecaps, and then an irritable bowel consultation with a gastroenterologist being fully investigated, and then all the way on the background there's been something suggestive of mast cell activation, and then they end up with us. So looking back, it's easy to say, well, why couldn't anyone have put this together? And I think that's a lot of what we're trying to do, is get the adult specialist at least to see those links. But with kids, it's another story. I've got 2 grandchildren, and my daughter-in-law is very hypermobile, and my grandson, who is 3, is not at all hypermobile. But my granddaughter, who is 1, is extremely hypermobile. Now, knowing what I know, I'm not too worried about her because she's walking and she's really active. And I suppose at the moment, what we're trying to do is say, don't protect those kids to the extent that they don't participate in exercise. Kids do better when they do more. But it's a very complicated area, and we don't have the answers. And you are right that some of our paediatric colleagues don't quite get it right. I've got one paediatrician in Kent who doesn't believe in POTS. Where do you start? It is complicated.
Absolutely. I mean, I think, so these are definitely other areas that we want to explore when we start our rounds of discussions with our paediatric colleagues. But we also have paediatricians, paediatric general physicians and rheumatologists in our consortium. And we are exploring all of these areas very much. And the message that I get across, that comes across to me from them, I think time and time again, in particular, is in the younger children, typically say up to the age of 9 or 10, it can be very, very difficult to be clear what the diagnosis is, but that should never stop you treating whatever the problem is. So treat the problem, not the diagnosis, is a sort of way forward. And I can see the sense in that, because it can be very difficult to know whether a younger child will go on to fully develop many of the features of, say, hypermobile EDS, as opposed to the functional issues in the there and then, which may be very physical, which would be very typical of themselves of hypermobility spectrum disorder. But actually, if you spend your time almost concerned about the diagnosis and don't actually clock that you've got a youngster in front of you with a set of symptoms that's having a functional impact, then you've kind of missed the point, because the problem doesn't go away. Now, the other thing just to bear in mind is that actually we've had, so the British Society for Rheumatology has revised its guidance that it wrote in 2013, and that came out very recently. And broadly speaking, it's useful. It's got lots of very sensible suggestions, and it would be good to see whether those suggestions have actually been worked through to be confident that actually the whole assessment's been done. The other thing to bear in mind is that the College of Paediatrics and Child Health has actually endorsed the 2017 international criteria for a diagnosis of hypermobile EDS. So if the signs are there and the diagnosis is endorsed by going through the criteria, then that is the diagnosis. And the issue that you then have is you're possibly working with somebody who doesn't know that level of knowledge. So it's a knowledge gap.
Okay, thank you.
Okay, thank you.